All right, folks. We'll probably have some people coming in, but we have a lot to talk about, and we have kind of a dream team today. So I think we might just jump into it a little bit. I want to thank everyone for joining us today for our Care Partners series with the Inova Parkinson and Movement Disorders Center. I'm John Dean, and I'm here with Josefa. So I'm a speech language pathologist. Josefa Domingos is a physiotherapist. And you can see on our screen, we have some great guests. We have our friend Nancy Hillmer, an occupational therapist in Colorado. She's joined by someone who's going to talk a little bit about their experience. Sandy, thank you so much for coming in. It's great to see you again. And then my good friend Bob Waldchen, a PT, who's also in Colorado, and he's joined by his friend Marcia, who's also going to talk a little bit about the experiences. And I'm really excited because we got a range of different experiences and backgrounds, but we are all people who are very passionate about working with Parkinson's. And today's topic is not an uplifting one, but I think it's an important one to cover. We're going to talk about the things you can do after you return home from a hospital after a fall, and ways you can make sure you get the right services and you get your house set up in a way that helps you, and you make sure that you're getting the kind of care you need so you don't have another one.
I'm probably here because I was a home care therapist for many years, and we had a certain model of treatment that really informed the way that I look at and treat Parkinson's and have for many years. So what would happen in our model of care, which probably is not what your model is, we had a team of nurses, physical therapists, occupational therapists, social workers, and home health aides who would go out when the hospital would call us and say, hey, we're sending this person home and they're going to need some care because they've had a fall. Or it might be a surgery or some other illness. It didn't necessarily have to be a fall. But if they had Parkinson's, we would send out our Parkinson's team, people on in our group of home care providers who specialized. And it really did make a difference because we were going there to treat not just what caused their fall and preventing that from happening again, or trying to keep them safe after their surgery and all the new precautions that they were coming home with. But we also recognize that because of the diagnosis of Parkinson's, we have more than one thing that we're going to be trying to work on. And it was a really great model to work with. So knowing that you may not have that model, I'm still going to be talking from that perspective because I'm hoping that maybe it'll give you some ideas that will help you to prepare yourself in case you go in the hospital for something either planned or unplanned. And, I've even been called in when it was not the person with Parkinson's who was going into the hospital. It was actually the partner of the person with Parkinson's. And it was anticipated that they would no longer be able to care for this. I'm thinking of this one gentleman who needed help at night, but his wife, after surgery, knew that she wouldn't be able to. So we got called in for that too. So there are all kinds of circumstances where it's really, really helpful to have somebody come into your home, see what's going on, what happened, now what do we do? We've got some new precautions. So we're going to jump right in. And I guess the first thing that I would look at if I were coming into a home fresh, not knowing anything else except the diagnosis, is I would say, okay, what caused this problem in the first place? If it was a fall, I'm going to be looking at, okay, how did it happen? When? Where? Under what circumstances did this fall occur? And I want to tell a little bit I want to tell a story about a gentleman that I did work with. We'll call him Bob. Not that Bob, but just Bob. And he fell at night trying to go to the bathroom. And he ended up in the hospital. They just came out with the EMTs, sent him in, and had him in observation for a while. He ended up not really injuring himself, but he was pretty shaken up. And so they sent him home, and they sent him home with our home care team. So we show up and we start looking at, okay, what caused this problem and how do we prevent it? So what I noticed as an OT, he did have some difficulty getting out of bed, in and out of bed. And so, of course, we're going to try to train some bed mobility. Maybe we'll look at some equipment like putting in a bed rail if that's appropriate and he's, cognitively able to manage it safely. We certainly would want to look at the bedding itself to see if he can maneuver it well enough by himself. Sometimes the heavy bedding and all the quilts and covers that people put on make it really hard to move around.
What did you get into?
Or if you've had an injury where you can't have something on your foot. I think my friend Sandy is fresh out of surgery.
Yeah. There's just, you have to realize, I went in for a surgery, so I didn't fall, so it was planned, but there's so much you got to think about before you even go. Like I'm looking at that picture of the cast and, how's that person going to get up in the night to go to the bathroom? And I see the crutches, which is like, doesn't work for me. I ended up using her mom's walker. But there's just all those things you got to think of before you even go in for a procedure that is scheduled versus a fall,
Yes.
So you got a chance ahead of time to get ready.
So we'll get into that in a minute. And back to Bob. I mean, one other thing that was going on for him was he didn't have any assistance at night. Mm-hmm. His wife lived with him, but chose to sleep in another room just to get some much needed rest. And that was something that was important. So we didn't want to mess with that. And overnight paid assistance is pretty expensive. So that's not always an option, unfortunately. So, of course, we could call in a social worker and see if maybe there was some kind of assistance or help that we could provide there. But certainly we would want to get a life alert system set up of some kind to help out in case there was another accident. Freezing of gait was definitely an issue for this gentleman. And it was made worse by a number of things. First, long distances. He could start off walking pretty well, but then the further he went, the more likely his steps were to get shorter and choppier. So the distance to the bathroom was an issue. Also, the number of maneuvers and turns, twists and turns that he had to make to get into the toilet was an issue. And so, of course, we could look at rearranging things. We could look at moving the bed closer. We could look at taking the door off of the bathroom. I've done that multiple times, and it really is helpful. We could look at putting 2 pieces of tape on the floor where your feet go so you don't have to make so many decisions at night. We could look at eliminating any kind of slipping or tripping hazards like throw rugs, and they did have a couple, in front of the toilet and in front of the bed, and it's just more things to have to think about. But wouldn't the easiest thing, which is not always the thing that people go for first, wouldn't the easiest thing be, why don't you put a bedside commode next to the bed and just not have to deal with all this back and forth? I mean, if you are going to do it, certainly, like Sandy, you were saying, having a walker.
Oh yeah,
was a helpful device. Maybe you don't need it during the day, but at night you do, especially after an injury, because you're less, your balance is affected, and you're less, you're more anxious, less confident is the word I'm looking for. Yeah,
and do you have a weight bearing or non-weight bearing issue? That's a big deal in the middle of the night when you got to go to the bathroom, and can I put any weight on that foot? That's a big deal. So you got to be prepared for that. How are you going to get there from here to there? Night lights, extra night lights, rugs out of the way, chairs out of the way. And then, like I said, I used a walker, and that was the way to go for me. So.
Did you have
Yeah,
any,
so all those things, sorry,
sorry,
were we gonna
Nancy,
say?
did you have any medications that you would take at night too, like a pain med that would probably help or interfere with that as well? Is that another issue, Sandy, or not?
Well, I did have to take the big boys because I had bone pain because they broke my toe to reset. And I was telling Nancy that yesterday after I took those big boys, it's a different world. You are out there, so I didn't take any in the night. I tried to just stick with the Tylenol, but that's another problem when you take the big ones because you are not normal. You are not normal. Yeah. So
No.
A lot of times people, when they experience some kind of a change, it's hard to really integrate that into how you see yourself, how you perceive yourself. I mean, this is an example of a patient that I had with a stroke, but it still applies. When you come home and something has changed, like for you, Sandy, the weight bearing, and you get up in the middle of the night, maybe you've been on pain meds, and we're all kind of foggy at night, especially if you've been dreaming or whatever. You may not actually remember that, oh, well, in this case with my gentleman who had the stroke, he just simply got up, started to walk across the room, and then realized when he was on the ground, oh yeah, my left leg is paralyzed. I forgot.
yeah.
Marcia has a good thing she wants to talk about as far as getting in and out of a chair and getting in the right position in a chair, what she developed that really worked well. Marcia?
I bought a king size satin or silk pillowcase and put like a baby's pad inside it so it was rigid, but it still had the drape of the rest of the material. When you slide on that, I take it with me to my doctor visits, to get in and out of cars. You know how if I had corduroy pants on and I get in the car, I stick.
Sure.
But you put the silky on, what I call silky, and you just glide in and you glide out. And it's much help in getting out of bed, getting out of a chair. So I've got a dozen here at the house and I give them out to my doctors. So
So satin pillowcase, and Nancy, that reminds me of what you used to do with bags too, I think, right?
All right.
yeah,
I've done it with bags. The other thing that actually really works are those flexible cutting board mats. Those are super wonderful for doing sliding board transfers when you get stuck, trying to scoot from one place to another. So I think what we're finding is that the more people you ask, the wider your support network is, whether it's professionals or people who have just been in the game themselves, you're going to get lots of ideas of things to do. I'm going to jump back to my guy Bob here real quickly just to tell you the end result, which was, we did work on the lighting, we did work on the toilet and making modifications there. We worked on his clothing choices so that he didn't have to struggle with so many buttons or ties or buckles or zippers or all that stuff. All those things were important. But the thing that really made the difference was we were looking at his meds and we found out that he was very, very under medicated because of some decisions that his wife had made about what he actually needed or didn't need. And that was causing his anxiety to just go through the roof. And when his anxiety was high, his freezing of gait was so much worse. And that really was the problems. All these other things were great. They were helpful. I'm glad we showed him these things. The medication was the biggest issue, and it was the reason. So anyway,
a lot of things.
Nancy, I
Yes.
want to, talking about medication, it reminds me of when we think about prevention and specifically to Parkinson, finding out what the cause of the fall was is fundamental, because imagine it's hypertension or orthostatic hypertension, which is something common. And so the probability of that continuing after is it's high, right? So it's the person had a fall, has a fracture, goes back home. Reviewing the medication will be important so that we don't have another fall, right? So I think when we think about prevention, it's finding out what caused it and can we stop it from happening again.
Yeah, so all the things that we did, those might have been really helpful in preventing a different kind of a fall, but the reason for the initial fall, as you suggest, was the orthostatic hypotension, or in this gentleman's case, the medications. Yeah, it's really important to get to the heart of it. And also, while you're there, you might as well throw in a few sprinkles of good advice that will help prevent a different kind of a fall.
Bob, I thought I saw you getting ready to say something. Did you have something there to add, Bob? No.
No, I think from my experience with hospital discharges, the more we can communicate with patients in general, even if they're not our patient, that the whole Parkinson's community is more aware of communicating to their doctor, their primary doctor, or their neurologist for sure, of what they need in the hospital. That make sure that the hospital knows their Parkinson meds, and if they're more anxious, make sure they're medicated properly with that. Because if they're not, as we all have probably experienced, if a person with Parkinson's becomes very anxious, they don't move well. They freeze more. They can't get out of a chair. They can't get out of bed. They just have a lot of difficulty. So I would say one aspect of prevention is communicate with the physicians in the hospital if you can. Now, that's sometimes a difficult thing, but that's what I would say.
And
Well, go
to
ahead.
schedule with the hospital in mind for Parkinson's is a unique situation. And if I hadn't had such an advocate for my husband, he came in and said, this is when these pills have to be given. This is the routine. And they were saying, no, this is our routine. And my husband finally said, I'll be in to give her her pills.
I mean, we hear this story a lot, and it's such an issue that actually the Innova Parkinson's and Movement Disorder Center made their own letter and set of reference materials. There used to be something out in the past, but Innova was finding that they could get better results and actually put one together for the people to take to the hospitals. And it also gave better direct contact so the hospitalists or the people at the facility could actually reach out to their clinic and get real advice. So I think we're all underscoring the same thing is Parkinson's is very particular, and it does not like the disruptions that happen when you go into a hospital setting. Yeah.
You know that I was looking through my old Aware and Care kit that the National Parkinson's Foundation used to put out, and that was basically the line of thinking for them was that you need to go into that hospital ready to tell them what you need.
Yeah.
Not wait for them to figure it out, because it's very likely that they will miss something with your meds, that they won't understand the vital importance of having the exact meds that you're on at the exact times, and avoiding certain medications. And that would be especially true if there's anyone listening who has Lewy body dementia. It's so important to not be given certain medications that are common, and they can really cause not only temporary but permanent changes.
Yeah, you need to be prepared by taking your own meds with you. I mean, I have had surgeries where they didn't want me to use my meds. Of course, they wanted to charge the insurance company, so they wanted me to take their meds. And then they couldn't even find a Cinnamon for me. This was years and years ago. But anyway, when I just had surgery this week, I went in there and I took my dose with me. I had 2 doses to take, one when I arrived at 5:30 in the morning and then another one at 11. And, she said, now, do you have your meds with you? Where are they? Can we put them in the locker and give them to you if you're still here? And so you got to be prepared for that, because they're not going to provide them. You have to take them yourself, however you carry them.
It's good advice, and I see that Sonia put the link in there for anyone who's looking for it. The IPMDC has a nice resource for this. And if you can't find it, if you don't know how to get into the chat, just send us an email, and Sonia will get one over to you. Sonia Gao, who runs this program for us. It's been
I carry this in my wallet.
Yeah.
Gave that to me, and her name is on here because
Sure.
I want somebody that will be available immediately if I have an emergency. And I know usually you put your doctor's name there, but
Yeah, so this is a little medical alert. I didn't know my name was on there until yesterday. But I will be there.
I know you will.
Have you
Yeah.
co-signed on her mortgage yet? No, I'm kidding.
Yeah. Anyway, it's really nice because, if you're in a car accident or something and
Yeah.
what do the EMTs do? They go, they look for your wallet and they pull out, whatever they can find that gives them information. And this has a very tiny little version. You can't see it. We can hardly see it. Medications that are generally acceptable and ones that are dangerous to administer, and then of course it gives you contact information.
Yeah.
So anyway,
Yeah, maybe
we'll move
move it
on.
through there,
Oh,
yeah.
sorry.
No, it's okay. If anyone has it, there's also a resource there. Is the Aware and Care kit around anymore? I thought they ended that program. Yeah. So again, however you get the information, but I know that the one that IPMDC has been updated at least, so their doctors are looking at it. So it's there haven't been a lot of new drugs, but there are some new dopamine blocking agents out there. For like bladder issues. Let me not take us too far afield. Let's keep it going, guys. Good conversation. Thanks for the input, everybody.
So moving along. All right. So now you've got all these restrictions and limitations from your hospitalization, and you're coming home. You're about to come home. So the question would be, what has changed now that I'm coming home from the hospital? So again, I'm going to turn it over to you, Sandy, for just a little bit here to talk about those planned visits to the hospital, which are different than the unplanned ones that we kind of have been talking about with the Aware and Care kits.
So yeah, if you're going in for a surgery that you're planning, I start paying attention, very close attention to everything about 2 to 3 days out. I make sure I'm on my meds at the right time. I'm careful with my diet. I make sure I'm eating a high fiber diet. I don't drink any alcohol for 2 or 3 days. So there's a lot to think about before you go in. Just make sure that you're really following your schedule. It's easy to get off schedule with your meds, but if you go into a planned surgery, if you've been on target, then your body's going to adjust a lot better. It really is. So, doing 2 to 3 days out and then paying attention to where you're going to be located most of the time before you come home. Are you going to be in the bedroom? Are you going to be in your chair, like Marcia was talking about her chair? Little things that can really annoy you when you come home if you haven't set it up. Like, do you have a cord there to charge your phone next to where you're sitting in the chair? Have you got your bedding set? I had to have my bedding a certain way because I couldn't have anything on my foot. All those things that really are annoying. And then the person that's with you, if they don't know what you're asking, they're not mind readers, and so you got to speak up. Oh, I forgot to put a thing down to put my glass on, or, just little things that add up. I need my pillow. I need a blanket next to my chair, so you got a lot of things to do before you go in. Now, the person that falls, that's a different story. They're not going to have the time to prepare. But I think the preparation before you leave for a planned procedure is really critical.
Sandy, can I ask you, so what was your biggest challenge now when you came home?
Well, when I came home, I had a nerve block in my foot, so my leg was numb, and that was very difficult for me to get around.
Honey, how was your trip down there? Did you find any cure?
Beg your pardon. Sorry, go back there. You had a nerve block.
Yeah, I had a nerve block, and so I had no feeling for almost a day and a half. No feeling in my leg, my lower leg, and my foot. So you can imagine, I'm trying to get up and do something. Thank God I had the walker. I treated it like a scooter. I just put my leg up there because, you don't feel, it's like it's not there. And that was the biggest challenge I had when I came home, was how to maneuver around, how to get to the bathroom with a leg that's, they told me to come home with crutches. I told her that, and she said, "Are you kidding
I
me?"
blew a gasket.
No way. I mean, they even had little pictures on my discharge papers. Here's how you use your crutches. I said, and I told her, and she said, "Absolutely not. You are not using crutches." But that was the worst part for me, is not being able to feel my foot at all, and it was very strange, very strange.
But that says a lot about the importance of having somebody who understands both the surgery part of it and the recovery required and the Parkinson's part of it. There was no way that I was going to let her come home with crutches. No way.
Yeah.
That was just, then you would be back in there for the fall.
Yeah.
Yeah. So with all the good intentions and
I wonder if we can ask Marcia what was the biggest challenge coming back home.
And Bob, I muted you for a hot second, so you're gonna just unmute again, okay? Did you see that? I muted you. I'll set you up there.
So that we just get some, and then I wanted to share some of the responses that people shared with us.
Yeah. What was your experience coming home? What was your biggest challenge coming home?
Making myself aware of my limitations was the biggest thing.
Yeah.
I had, if it hadn't been for Bob and my husband, I would have been in a very bad situation. But because the two of them worked together and worked with me and the hospital to come up with a solution to some of the care positions, it was it evolved to be rather seamless, going from the hospital to here. But knowing when to call for help and when not to try to do it myself was always the biggest hurdle I had to overcome.
Forget your independence. The first
right, exactly.
Forget it. You're
And don't
totally
be shy.
dependent on your helper.
Yeah. Marcia's not shy, which is why we get along so well.
Yeah. Okay. So you got there and you got the support there, and were you working with Bob before you went in, or was this no? Bob he just came in and like, by the way, you've hit the lottery because I happen to know a thing or two about Parkinson's.
I came in 4 months after her hip replacement. She had a hemiarthroplasty, and I came in 4 months later. So nothing much had been done. They did what they could. They did okay in rehab, but then they sent her home to traditional home care. They had no Parkinson's specialist, and so
That is
it ended up being something that my husband and Bob worked on together to identify the areas of most concern in the house, and then they were brought to my husband's attention, and he fixed them.
So I think sometimes that's the biggest resource we have in a home when there is a care partner and a therapist comes in. It's not just the patient we're working with the care partner to provide them helpful hints, information, resources, because it's so easy to get overwhelmed if you don't tap into that.
And I've had Parkinson's identified 26 years ago. So it's been a while since I haven't had to face something to do with Parkinson's in a daily atmosphere.
Right.
One more thing about when you're being discharged. For me, for example, I had just woke up from anesthesia, right? And they're going through all this discharge information about how to take the meds and da-da-da-da-da-da. And I'm like, I didn't remember a thing by the time I got home. Mm-hmm. So that's a problem too. I mean, they're in a hurry to get you out of there when you're on an outpatient procedure. But that's another important thing, to have your partner there so they can listen to what they're talking about. And I mean, I had to keep referring back to my packet about when I could take that drug and could I mix it with Tylenol, and they go through all of that after you wake up. I mean, apparently the doctor came and talked to me, and I don't even remember that.
That seems like malpractice, doesn't it?
Is it legal for you to ask to record what they're saying or not?
Well, I don't know.
I think you can.
Yeah, probably.
Most people don't, but I've had people who have done that. Even, like when I was going in with my own parents, I was so distracted at times by all the things that were happening, and that it was helpful to actually take a recording on my phone.
Yeah, that was smart. So anyway.
One other thing, Oh, sorry.
I said that should be included in the go home package and where to go for help. That was our biggest issue is who do we contact? Where are our resources? What will they provide? How are they going to relieve some of the constant pressure on the caregiver to perform outstanding works or feats of matching up the pills to the situation and knowledge of the pills, and it's an amazingly daunting thing to see it in words.
And it was happenstance that I got to Marcia because one of my colleagues that I had worked with in traditional home care was the therapist who came to see her, and she got in here and said, I don't know much about Parkinson's, and she called me and said, hey, can you get out and see her? So,
And the teamwork was amazing.
yeah.
I mean, again, it's very lucky, and it's sad. I mean, there's not enough people that really know Parkinson's in a lot of environments, but I think home care, boy, what a place to have an impact. And again, Bob, your mobile outpatient model is, if I was in the States, I would absolutely be doing that. That'd be exactly where I'd be working because you can do a lot of good.
Well, I'm excited, John. In the last 15 years of specializing in Parkinson's, I've been asked to present at my company's annual conference, and I am excited.
Yeah.
Scared to death because I don't know PowerPoint, but I'll figure it out.
Good for you, Bob.
Good on.
Okay.
You got a
I
media
wonder
specialist right there.
if
I
could
know.
I
share-
know. I just told him, I said, I can help you with that.
Yeah, there you go. I'm sorry. We have to take it to
Yeah,
field
I
here.
just wanted to take just a quick moment to share with you. We did send out a questionnaire to see if anyone that has gone through the situation in terms of what would be the biggest challenge. So to the question that we asked, what was the biggest challenge coming back home? People mentioned different things, and one of them was the stuff I needed was not accessible, medications were not organized. So I think all these, what you're going to hear now probably will validate a lot what we have been discussing. Another opinion was having to rely on others, not being able to drive myself anywhere and to do things while using a walker. Okay, the challenge of mobility and moving from spaces. Then we had another challenge that people mentioned was balance and fear of falling again. Another one was only after a chair was installed on the first to second floor for bedroom. So the biggest challenge was reduced after. Not another comment was not supposed to get out of bed without brace on, and getting it on for night bathroom visits was probably a big challenge.
Yeah, like
I
you got to
don't
go to
know.
bathroom, and I'm like, let me get this brace on. That sounds terrible, actually.
Yeah. We had some others that were, so shower safety was a concern and a challenge. Asking for help was hard for me. Asking her to help me with the exercises PT gave me to do. Getting him to practice every day. So again, motivation and then for the exercises. And then we also had not able to wash hair for 6 weeks. So, and finding suitable clothing to wear to walk around the village. So had to fit over a brace. So depending on what type of fracture we have, we will have more limitations on this. And then finally, we had someone that commented, not knowing about community resources I wish I had found ahead of time. So these were things that people share, and we thank everyone that shared, because it's getting different information from different sources that I think will help us be able to tackle these issues more. And now we
Yeah, I think one of the most important ones I read there was making sure you have a chair in the bedroom.
Mm-hmm.
You know, that's really important to be able to not sit on the bed, but sit in a chair when, you know, you're trying to do whatever you're doing to get dressed or, anyway,
Okay.
I thought that was a good one.
Yeah.
I think the whole idea of adapting clothing and your home to your situation is just so important. And again, if you knew ahead of time, that would be something that you could work on. You could also work on some of the predicted restrictions or precautions, like, for example, log rolls. If you're going to have a back surgery and you know you're going to end up having to do the log rolls, do you know how to do them? Practice them while you can before the surgery, because it just gets more confusing with everything afterwards. The more practice you can have, the better. Or if you're going to be non-weight bearing, and you're going to have to get yourself out of a chair or into the chair with your foot out in front of you to keep it non-weight bearing. Do you need to be doing some push-up exercises ahead of time and just practice that skill and the body mechanics to help you do that? Or up and down stairs, up with the good, down with the bad.
She caught me last night. I did it the wrong way.
But anyway, yeah, all those things that you can practice, and then yeah, there's a lot, but certainly having, I mean, I've got to put in a pitch for OTs. That's what we do. We go to homes, we look at your situation, see what it is that you've been told you can or cannot do, and look at your circumstances and the available resources, and we just try to make it work with what's there. And we tend to be very scrappy therapists. We use whatever is in the house.
Yeah.
And whatever we can find in loan closets or catalogs or whatever. There's so many resources and so many creative ways to deal with problems that I would always tell my folks, hey, there's probably 25 ways we could solve this problem. Now, let's just start with one and see how we go. But yeah, getting people back on track after surgery or falls or injuries is just really important, I think. And getting people back to doing their daily routine, I think is not only good for your body. You have to use fine motor, you have to be quite flexible to reach everything. You have to have some balance. You work on a lot of things just going through your day-to-day routine. So it's important to get back to that, but it's also important for your head that you feel like, I can still do that. Another story that comes to my mind of a patient that I had, now she had a stroke, but again, same kind of thing. Her big thing was she wanted to be able to put a bra on more than anything. And she lived alone. I said, why do you care? I mean, that's my thing. I would say, I don't care, but she cared. She really cared. And so we really worked on it. And it was hard because she had a paralyzed arm. And so we we tried numerous things and kind of landed on one. She tried it. I went home, came back a couple days later, knocked on the door. She says, come in. I walk in the door and she goes, oh, Nancy, look. And she whips her shirt off and shows me, I put my own bra. She was so excited. That was it for her. Yeah. She reached the moon. Yeah. And those kinds of things, I think we are kind of underrated when we talk about recovery. It's what the person wants. It's getting them back to their normal routine. So, here you are, a week, not even a week out of surgery, and Sandy shows up at class because she really wants to be there. I mean, It's a great class.
It's the social part of it, the camaraderie that I have with the other people in the class. And of course, I couldn't do the stand-up things we did, so I just did what I could in the chair, so I had to adapt to what I was doing. Just like when I left here last night, I asked her if she had an old shoe that would fit over my surgical foot. Because as soon as I get my stitches out, I'm going to get on that stationary bike, because I can't do my walks for a while. But, you just have to adapt to what you do. And because otherwise, I'll lose it. I'm used to working out 6 or 7 days a week. So, I've been a slacker here since Tuesday, and I'm like, okay, I got to do something. So today, I got on the floor on my mat and did some stretches. Whoopee, right? But at
You're
least
right,
it was
though. Losing that exercise edge, I mean, it's a big deal. I think I noticed it myself, and and not living with Parkinson's, it's valuable.
Yeah.
I think
It's
it might be a interesting source of new type of anxiety because we're receiving the message of exercise is the one thing that you can
I
do.
know, I know.
Rigorous exercise, and then suddenly you have this major change in your life, and it's like you might feel like you're failing. I've heard this before from many people, and it's just reassuring people that your body is as it is now, and you can do what try to adapt the exercises. Don't feel like you are failing on something because it's what
I know, I know. I'm just a little
yeah,
over the edge
perfectionism.
on
I
that.
know.
Yeah, I admit it. I admit
She's a hard worker.
it.
But since your diagnosis, you have had what? Shoulder surgeries,
Yeah.
elbow,
Yeah.
back, multiple foot. I don't even know how
Yeah.
many surgeries you've
Yeah,
had in all different
yeah.
parts.
Yeah.
And the thing about it is that we still had to find ways to keep up with the Parkinson's exercises, no matter what. And most of them, you can find a different position
Yeah.
to work on your posture. You don't have to be upright. You can be in bed, flat in bed.
Yeah.
This is why Bob was such extremely important to be able to provide this at home, is because I was able to continue to improve as much as Parkinson's will allow you to improve. I couldn't have done it without him.
So I think one of the ingredient that I find has been very helpful is when I come into the home for the first time, listen. Listen to where they're at, where they used to be. What do they want? What are their goals? What do they want to be able to do that they're not able to do, that they're very frustrated or angry about whatever they're doing. So really listen to get a good idea of what's going on and then give them hope. So sharing a story about another client that you've had who's gone through something similar and done well, okay, particularly the person who is down. Sandy looked and Marcia looked like very highly motivated, positive people living with Parkinson's. Not everybody is. I come into some situations and they're down in the dumps and they don't have much hope. And they go like, oh, this is it. I'm done. I'll never walk again. I'll never do this. I broke my hip. I did this, whatever happened. And so to give them some perspective on hope that they can go forward.
Yeah.
Everyone's got to feel that they can improve. And again, you can pick a key area that they can focus on to improve. I think it always makes it's an achievable goal. It's not like I want to fix this problem or this problem. That's great, but what's right in front of you that you can do something about, and you move from there. Really good. Yeah, again, really good stories, Bob.
Practically speaking, when a person comes home from the hospital after a fall or an injury or surgery, there are a number of things that you can expect them to go over with you. There's going to be talk about preventing infections. There's going to be talk about watching out for skin breakdown, blood clots, pneumonia, and of course falls again. And then looking at your general post-op precautions and all that, and pain management and keeping on top of that. So, there's a lot going on and a lot of things that suddenly become more convoluted and interchangeable, like balance, for example. When you come home with any part that's not moving in the same way it used to, it's going to throw off your balance. It just will. Or if you've got pain in a certain part of your body, it's going to throw off your balance. It will. And we already know that with Parkinson's, it just requires more concentration on every movement. So now you're being distracted by this pain or this restriction on top of the fact that it's affecting your balance. Then you throw in the pain meds and they can add to dizziness and confusion or drowsiness. You throw in constipation and the need to, again, stay active. We want you to be active. So that one, I think, is across the board. But, changing your diet to try to accommodate that. Pressure sores were one that we saw a lot in home care. And we really worked hard to prevent those. And they're, something that you need to be aware of if you're ever in a immobilized situation, whether in bed and you have to watch your heels, or maybe your spine or your hip, or however you lay down, just keep moving in different ways. Or if you're sitting in one position for long periods of time, you can have skin breakdown around the bony prominence in your tailbone. And that's really tricky to treat because, you've got to keep it clean and dry and treated, and it's tough. So there are things that we do to help people to prevent pressure sores, things that you can do physically, like, heel protectors, elbow protectors, cushions on chairs and beds, all those kinds of things. But really just keeping on top of it, knowing that you're looking for those things to start with and preventing them. And of course, pneumonia is another one I wanted to mention because it is more common in people with Parkinson's, and it is something that can happen after a period of immobility as well. So lots of things that we're dealing with.
I was going to talk about for a second, if somebody's going in for surgery where they're going to have an incision, you worry about infection when you get home. So that's something else you need to do before you go, is get your supplies ready. I mean, first of all, my discharge paper said, don't change your dressing till you come in 10 days. I'm like, are you kidding me? I'm bleeding through the gauze now. There's no way I'm not going to change the dressing. And so you got to have all your supplies. So I have a little bucket that I got the gauze and the tape and everything, and what I need to clean it up. And, the first few days I was changing the dressing probably 4 times a day because, your incision is still bleeding, really. I mean, so that's real important that you have all your supplies before you go, ready to go. Where are you going to sit? Where are you going to change your dressing? Going to do it in the bathroom? Okay, have your stool, your chair, all that's got to be there and ready to go. So, and so that was difficult for me, especially when I didn't have any feeling in my foot and I'm trying to change the dressing, but I had to because it just kept bleeding through. So, a lot of people don't think about that before they go. Oh, I'm going to have an incision. Yeah, you're going to need to change your dressing. No question. So.
And then how do you do your normal grooming, hygiene, bathing when you have this whatever
thing on my foot with this boot?
Do you need to have some kind of a cover? And they make some really excellent ones now that we didn't used to have. We used to tape up everything, and bags and all that stuff. Well, now they have quite a few different really nice, easier products called cast guards and the like that can help. Or we've come up with dozens of quite creative ways to do washing hair and stuff. There's just, it's hard to really describe all the scenarios, but again, that's what people who have been through it before, especially your OTs and PTs who have seen all these things, nurses, CNAs, they're all really good at coming up with solutions.
And taking that first shower, first of all, I fortunately, because I had my bathroom remodeled, and Nancy went over and met with the people and said she needs all these bars, and they were like, really? Well, I use them all the time, and especially when I took my first shower after this surgery. And, you got to have somebody there just in case, but I mean, you're holding on and you've got, you got all that to deal with, and then I've got a stool in there to put my foot, which I'm still not feeling, and I've got the plastic boot cover over it. Those are pretty slick. They're expensive, but they're worth it, and so then if your foot gets wet, I mean, it's just the plastic. So they're real good at keeping dry because they're real tight. You put them up above your knee. And, but that first shower, you really need somebody there to make sure your balance is okay.
Bob, and Marsha, did you guys work on setting up the house after you got back? I mean, was that something that Bob came in? I mean,
Yeah,
Nancy, you're a MacGyver, but Bob, again, on PT's same
yeah,
situation.
um, we were fortunate. We had Marcia's husband who was doing a lot of everything. Like he's like a MacGyver. He tries to fix things and get things right, and very particular, which was great. But Marcia and I worked a lot on just doing the best with what we could with what we had. And yeah, so it's been a really good process. And we're still learning things.
Sure.
And we've been working together for almost 2 years.
Wow.
Again,
So that to me is a real testimony to the value of the model that we work under. Mobile outpatient therapy affords us that. We don't have the financial restrictions that traditional home care have. So people say, well, why do they need ongoing therapy? Because things change. We're trying to keep Marcia up at a much higher level than she would be. She's probably would be rated a stage 4 right now, but she functions at a stage 3 a lot of the time when her medications are working.
That's
So,
the key. That's the key.
and she's so much happier and functioning that she can do things. So,
yeah, I mean,
Is
again,
that
it's part A stuff. I mean, that was back in the day, but it sounds like a really good approach. I really
is
like
that a
it.
specific model from Colorado?
No.
no, it's not. It's not specific to Colorado. It just happens to taken root here. I mean, it's really expanding. Our company has 95 therapists between PT, OT, and speech throughout northern Colorado, all the way from Denver north. And I think even some parts in Colorado Springs. So, it's expanding and the need is huge because home care agencies can't provide the care that they need to. They're limited, you
Yeah.
know?
I mean, what a home care agency gets is they get a pile of money at once, and
Yep.
it's like do all the care, and that means that decisions get made. Now, there are probably home care agencies that are focusing on one area or another, but with Part B, with Jim and Sibelius many years ago, it's like we have this mechanism for saying we're keeping people on because we're reducing the rate of change. So again, Part B makes so much more sense.
And also, it used to be that we had to show a specific amount of progress, like you couldn't stay on. It's now, can we show skill? And
Mhm.
we show skill every time we're in because we're keeping this person, working with them, keeping them at a much higher level of functioning. And this is where OT and PT overlap.
Yeah.
People tease me. They said, Bob, you sure you're not part OT? And I said, well, they do overlap. I mean, OTs work on transfers, PTs work on transfers, bed mobility. We work on a lot of the same things, but the OTs are really great at coming up with novel solutions when what we traditionally do isn't working. And they'll say, well, have you tried this? Have you done that? Well, we could do this. And so it's great.
I do have some OT envy. I'm sorry, Nancy, we're not trying to pick on you, but I think OTs are really. When I got out of grad school, I was like, oh, there's a whole profession that does nothing but be creative all the time. I wonder what I could do with that, but it was too late.
It's a lot more fun.
Yeah. Anyway, so,
Yeah. I wanted
yeah, go ahead.
I wanted to highlight something. As I hear all these challenges, and I can imagine everyone here also listening to this. You have this, and you have this, and you have this, and this, and also all this. I hope that we can look at it and remember people get through it. Isn't that amazing?
It's
So
too short fast.
it sounds so messy, right? And so challenging, but it's amazing to see the frequency, unfortunately, is a lot, which means people are getting through this process. So it's possible. So at least I want to leave that message of hope to look at it in that way, in what we are sharing, is that people are able to get through all this.
And there are
It's
more
amazing.
options than there were 5 years ago. It kind of feels like a Dr. Faulkner thing. Like we have more medication options, but we also have more treatment options than we did 20 years ago, 10 years ago. I mean, Marcia, if you've been doing this for 25 years, 26 years, that's back in the day of medications we don't even have on the market anymore. We got rid of.
My mother had Parkinson's, and the medication they gave her is the same stuff I'm taking now.
Oh, really? It's in a Yeah, there are some ergot-derived dopamine agonists that are now gone. But yes, yes. I mean, a lot of it is from the 60s. I'm being careful. I'm looking at the clock. I want to make sure. Did anyone we have a nice group of people here. Does anyone who joined us online, do you have any questions or thoughts we can answer for you? We just, again, I feel like we got the dream team here. Bob, it's been great hearing your insight. Marcia, obviously giving your real boots on the ground. And then Nancy and Sandy, gosh, I've known you guys now for a bit. It's been good.
Being
People
stubborn
just,
doesn't help, huh?
you just have to know that when you go through something like this, whether it's a fall and that wasn't planned or a planned surgery, it is going to be extremely difficult for 2 or 3 days, like in the extreme category. Everything is different. Nothing's the same from when you walked out the door. I mean, it's just going to be hard. But this too shall pass. That's what you got to remember.
I think accepting the help,
Yeah.
knowing that you will need the help.
Yeah.
So that's a good start.
Yeah.
And then recruiting the help, not being isolated. I just think that is one of the biggest things, is try not to isolate yourself, even if it's getting on that phone, which is good. Speech therapy, by the way.
Absolutely. Zoom is
One of
awesome.
one of the things I wanted to mention again was something that doesn't even just pertain to Parkinson's, but you mentioned about this thing about people out processing while they're doped up and they can't understand. That really ought to be something that's done something about. That shouldn't just continue to go on generation after generation. I don't know if there's an effort to fix that, but that's got nothing to do with really particularly Parkinson's. Anything where you got drugs in your mind and being told important information, that's got to stop.
Yeah.
That seems like malpractice. I 100% agree.
I heard you say that.
It should be written, and now with all these transcription apps, is that you should be able to record it and just get a printout of it, because it's terrifying to think.
And when you have an outpatient procedure, they want you out. Get out of here. They need that bed for the next person. So they don't give you a chance to calm down and get out of your anesthesia so you can understand. Like I said, I don't even remember part of it. So
Probably get you to write a review on Google right then, like, "Wow, you're feeling really good. You want to tell us how to give us a testimonial?"
How do you think you can protect yourself from that? So, and until we change others, because this is a question of good sense of the health professional and unfortunately the system as well. So as a person with Parkinson, how can you defend yourself? And that's why I was thinking about the recording. Or
yes, I think that's, yeah.
standing up for yourself and say, like, I can't hear you right now. I need to record, or I need you to give me some time, right? So sometimes I think we are too fearful of saying that because the professional is rushing. And it's like, I'll understand you quickly if you give me some time and do it slowly, right? So I think it's just empowering people to know to defend themselves a little bit more in that.
Well, I want to point out too that Sonia has put together a nice set of resources on falls on the ipmdc.org website. So you can go there, /falls. She put it in the link there, but I'm sure you can find it on their website. But you might brainstorm a little bit before you go in, just like you did when we're all talking here, so that you're a little bit armed. Because it'd be really, hi, I just came out of surgery. I'm not feeling great, and I'm on whatever anesthesia. Now let me do some decision making. There's a reason why they don't let you drive.
Yeah.
Right. Yeah. They won't let you drive, but they'll have you sign that paper.
Oh, that's right.
And
Hurry up and get out of here.
Bring your
A
care
lot of times
partner.
they won't let you sign the paper. They'll have somebody who has to be with you. But again, choose wisely.
Yeah.
Choose somebody who you think will understand what's going on, and be the best advocate for you. And it might not be the person who you're most closely related to.
Yeah, and bring that care partner, if they can, into the room where they're discharging you.
Yes,
So you have
absolutely.
another set of ears listening to the instructions, and that way you don't just get shuffled off.
Well, just opening the floor one more time before we wrap things up. Does anyone else have any questions? We're here. This is why we're here. And again, I would say, Bob and Nancy, I'd say probably we have like 70 years of treatment experience, maybe 80. I mean, we've all been doing this for a long time, and pretty exclusively in Parkinson's, at least for 15, 20 years each, maybe longer for Nancy. So anybody have any questions? Yeah.
When can we do this again?
Yeah, that's a good one. Yeah, fun time. Well, I don't know, fun, but I'm a nerd. I like to talk about this stuff, and I like talking about with people who know what they're saying, right? So,
We hope we shared some solutions, but I did want to maybe end with sharing some of the tips that
came from others.
Yes.
You get that one, I'll get this one here.
So these were just quick suggestions regarding the question, do you have any advice or tips that you would like to share with others that I passed through the same situation. Now my eyesight is not good, so I'm going
Okay,
to.
sure. The one set that's at the very top in the upper left-hand corner sounds an awful lot like what we heard from Sandy and Marcia, which is be prepared. Pack a survival kit similar to what you'd have for a weather event. Don't resist learning what can make it easier for you. Set up a contact list. I think that really helps. Is getting to isolation. I love this, and we did this a lot during COVID. Learning how to order groceries online. Realize that the healing takes time. Practice patience and keep your spirits up. And I think your point before, Josefa, about we've been here before. We'll get through this. It looks painful. It's a big mess when you first started, but you won't be the first person who's gone through this and gotten through on the other side. I think that's really valuable.
I think understanding how fatigued you will be when you come home, because recovery takes a lot of energy. Even a recovery of a small part of your body, all of your energy goes towards that recovery, and you might be amazingly fatigued. So don't get down on yourself. That's just part of the healing process.
Totally. The great insight, especially at surgery, if you got an incision where they've done some real work, you're going to be hurting. And then the meds will make that more. And I think two of them I really like, don't fall at all if possible, or don't fall if at all possible. That's a good one, yes. And then be vigilant and watch your step. And then the exercise is important. And this is another thing. I think our online classes that we do, when you can't get into a club, it's a great opportunity to do something online, and it also gives you some social connection, and you can perform it at whatever level works. You don't have to be, when Joseph is doing a Zumba, we have a guy that not living with Parkinson's who had an injury, a freak injury, and there he is in a chair doing the magic. And I think that I love that story just because you can see it.
And the online video is so helpful for follow through between your therapy visits. So if therapy's coming out twice a week, you got 5 other days, you go online.
Well
You can't
said.
get out of the house. Absolutely.
Yeah.
Your lips to God's ears on that, Bob. I think you're right.
There you go. Just check out John and Josefa's channel.
Well, again, all supported really due to Sonia's efforts. Sonia has supported so many great programs since she started at IPMDC, and we really are thankful, including today's program. So I think this is a good place to close and just say thank everyone for coming in here. We'll have this material online so you can get the reference. And I want to say a special thanks to Bob and Marcia for making it in there. It's really great to talk to you. And Nancy, you always have great insights. And Sandy, it's great to see you. I'm glad.
Better by Sandy.
Yeah, I can't believe you just had surgery 2 days ago. But again, because I know you a little bit, I can absolutely believe it. That sounds like exactly the Sandy I know. Yeah.
Thanks for having us, John.
Yep, thanks, John. Thanks, Sonia.
Thank
See you,
you.
Josefa.
Thank you, everyone. Hope
Have a
it was
great one.
useful.
Okay,
Thank you.
bye.
Coming in.